Hi, everyone. Greetings from Seattle. This is Jerry Radich from the Fred Hutch. And today we're going to talk about when we should consider allogeneic transplant for CML in the age of the tyrosine kinase inhibitors. So the big old question is who, when, and what. Who should we transplant? When should we transplant? And what type of transplant should we give them? And I'll try to address most of those things in today's talk. The first thing is historical perspective. Transplantation is now 65 years old. This is a copy of Don Thomas, my first mentor's paper from the New England Journal. And for those of you who didn't have the pleasure of meeting Don, he was a laconic West Texan with a wry sense of humor. And I dare anyone to be this clever in a New England Journal paper these days. He said, in an atomic age with reactor accidents, not to mention stupidities with bombs, someone is going to get more radiation than is good for him. And that's important to remember because when transplantation started, it wasn't meant as a way to cure leukemias. It was meant as a way to cure people with radiation sickness, which people saw as an unanticipated or as anticipated complication of the nuclear age. And so this is actually just to remind everyone where we are in transplantation. Now, when I started transplanting 30 years ago, a little bit more, the figure at the top was the case. It was really a young person's gain. So even in 1980s, with just old-fashioned TBI and Cytoxin, if you were less than 20, you did spectacularly well, but then it marched down by decades, so that when you were down to my age, your chance of chronic phase survival with an allogeneic transplant was very low. But here's the results 20 years later, and for this is again our allogeneic related transplants. In the age of targeted busulfan, Cytoxan, modern antifungals and the like, survival for a person less than 21 is essentially the same as someone who's 65. And this is from my colleague Ted Gooley looking at non-relapse mortality following transplant, showing the trends from the days after transplant for those from 1997 and before, and 2007 and to 2003. And you can see there's a really dramatic difference in toxicities with transplantation. And the reason that I bring this up is that when we think about alternatives to tyrosine kinases in patients that need them, we should not be reluctant to go to transplantation because in fact, transplantation has an excellent outcome, especially in chronic phase. And right now it's probably underutilized. But tyrosine kinases happen. So this is the survival curve in chronic phase on the left from M.D. Anderson by decades. So in 1965 here or so, this is when you had no therapy. So everyone kind of went to chronic phase to accelerated phase blast crisis with an average lifespan of less than 7 years. And as you kind of went on with interferon therapies and now TKIs, these patients live essentially in a normal survival now compared to the normal population. And this is what happened to transplantation rates. The blue curve is with chronic phase transplants from the EMDTR. And here's the introduction of imatinib. And predictably, and as it should be, transplantations have completely fallen off the face of the earth. And that's the power of the tyrosine kinases in taking care of patients with CML. And what this has effectively done is turn this. This is a month's supply of transplant medicines in the outpatient clinic. So no wonder we run around it looking at drug-drug interactions a lot. And this is what goes into the people. And this is what it's turned into, this one pill a day. This is Tim Hughes' head. I outlined this here because the lawyers have obviously got involved in making this poster because this actually says not actual size in case you were fooled and thought that you had to carry around a 4-foot pill and on it all day if you had CML. Not the case, do not worry. And where we've made our major effects in tyrosine kinase therapy is blunting blast crisis. These are cumulative incidence curves of blast crisis from the old days. This is from the European data, and marching down until really the age of imatinib. So now blast crisis is much, much rarer in our population. But it means the same worse things that it did 20 years ago. This is the curve of looking at survival after progression to accelerated phase with blast crisis on the ENIS and D trial. And you can see that once you progress, your median survival, even in the modern age, is 50% die by less than 12 months. So your key thing in treating patients with chronic phase is to keep them from progression. Now, one of the things I want to remind you is that resistance to tyrosine kinases happen. When they happen, it should be taken seriously. So this is the data from the Hammersmith in people who are on imatinib and then get a mutation. And then this is their progression-free survival. A bunch of studies show this in Adelaide, with Simona Sovrina in Italy, that before their introductions of second-generation TKIs, a lot of patients who progressed went much more quickly into accelerated phase of blast crisis than you might expect. And the reason is probably this. This is studies that we did and others have shown this as well, in that there's an overlap between the biology of resistance in CML and that of progression. This is a heat map of gene expressions comparing chronic phase to blast crisis. These are 3,000 genes that are deregulated in blast crisis compared to chronic phase. And you can give people a score where these are the most chronic phase-like patients just based on the intensities of the upregulation in red or the downregulation in green. And these are patients in blast crisis here. And this is the score you can kind of assign them. All these dots here are patients who were resistant but in chronic phase. So they initially achieved a complete cytogenetic response, then they came out of response. They still look to the pathologist like chronic phase disease, but the gene expression signatures, as you can see, often look much more like accelerated phase of blast crisis. That's been verified now in some mouse models as well. So it kind of explains why patients who become resistant may be on a little bit different pathway in their speed to progression and need to be really taken seriously and thinking about where transplantation might fit into those patients. This is just an example of the CML, just like every other cancer, is a Darwinian selection process. This is from data from Neil Shah showing that patients who presented with a mutation after in resistance then got a second drug, and they become resistant more and more enriched with the 359 mutation or with compound mutations. And these are just some examples of the literature of kind of clonal evolution that occurs in ALL, where you can get divergence evolution, or convergent, where two different pathways lead you to a clone that has the same mutations. And this just shows how Darwin had it right altogether. This is his notebook from the speciation of the finches, which looks very much like this and some other cancers that you can see. And here I love this because Darwin writes in his notebook, "I think," as if to say, I think I have the best idea in 2,000 years. Here's another example from Tim Hughes showing this sort of evolution that goes on. It took patients who had imatinib resistance, and when they're resistant, they either have wild type ABL in the face of resistance, and those are patients that we really worry about, because in this case, the resistance probably is not dependent on BCL-ABL targeting. It's probably some other pathways that are involved, and therefore a little bit out of the range of maybe what you could recover with another second generation drug. And here are patients with a baseline mutation. The patients with the ABL mutation, when you gave them therapy with another line agent, they progressed to accelerated phase of blast crisis, and they still were wild types. So they didn't really accumulate any new mutations. Those with baseline mutations either progressed with the same mutation or evolved into a new mutation. So again, the pressure for Darwinian selection is ever present, and one has to worry in cases is if mutation is really forever. If someone who, once they become resistant, if you're going to be putting basically molecular whack-a-mole until finally they get a clone that's going to be going into accelerated phase of blast crisis. This just shows that there are a number of second-line therapies you can use for people who become resistant. The main thing to look at here is that not that many of them go into complete cytogenetic response. Their progression-free survivals are not all that hot either. So I think when people progress on their first-line therapy, you can put them on a second-line therapy, but you really should be thinking that these people may need a transplant down the line. In our center, what we usually do is if someone becomes resistant to a first-line therapy, we start them on second-line therapy, and we start the unrelated donor search or some type of donor search at the same time, so that we can look down the line, and if they are not responding to the second-line therapy, move to transplant before they go into a accelerated phase of blast crisis. And this gets to this point of how long you should try salvage therapies. These are two studies. The top panels are from the Hammersmith, the bottom two are from MD Anderson, showing basically that after 3 months, if you don't see a response to your second-line therapy, it's probably time to think about some other therapies such as transplantation. And that's about a convenient time because it usually takes about 3 months or so to secure a donor. So you could start a patient who is resistant on second-line therapy. When you find a donor, assess them. If they've had a good response, you can just keep going. If they've had no response, then you can consider the possibility of a transplant. Now, we have many options for transplant, and we like to say in the transplant world now that we can essentially find a donor for anyone. Donors are available in most patients. We can get related, unrelated, haploidentical, umbilical cord. In CML, there isn't a lot of data for umbilical cord donor or haploidentical transplants, but in AML and ALL, there are. And if you look in those diseases, the survivals for all of these types of transplants are virtually the same. They just have different complications that balance out their survival characteristics. But if you look at those in the acute leukemias, basically all those types of donors work essentially the same. Again, they have different competing risks of GVHD, some have more relapses, some have more infections problems. Preventative regimens are available for most patients. We now have all sorts of flavors of intensity of therapy from completely non-ablative to fully ablative. So we can really usually match the type of therapy that they should receive as far as being able to tolerate with the possibility of getting a donor. But as I say here, not all experience for some of these options in the CML setting, although you would think that probably the nuts and bolts of transplantation will relate pretty well from treating acute leukemic to treating a chronic leukemia. This is now looks at some of the updated data. This is a center from the Hutch data looking at all comers for chronic phase on the top, accelerated phase, blast crisis, or blast crisis remission, out to about 20 years. And the point here is that if you're going to go to transplant, it's a lot better to transplant in chronic phase than in blast crisis. This is data from the International Registry looking at unrelated donors from 2001 to 2011. Again, showing that there is definitely a difference in the survival if you treat them earlier than later. Blast crisis is not shown here because a lot of centers will not transplant blast crisis with an unrelated donor because of how unfavorable the results are. This is from data from Germany, again showing that patients who, even in imatinib era, they have fantastic survivals, very small ends, but you can safely transplant someone in a chronic phase nowadays and suspect a survival of 85% or more. Now, you can do reduced intensity or non-myeloablative transplants in chronic phase CML. This is data from 2 studies looking at the survival is not quite as good as in chronic phase. This is when there wasn't a lot of experience, and early on in the non-myeloablative setting, rejection was more of a problem in chronic phase patients because they hadn't seen a lot of immunosuppression before. But I think that nowadays you would expect for a chronic phase patient for all of these curves to be pushed higher. Obviously, they're more attractive in patients who are older and can't tolerate an ablative therapy. Now, a couple of other caveats to think about. One is that accelerated phase patients differ in outcomes by when they are declared accelerated phase. These are just 2 curves showing that with either imatinib or second generation TKIs, people who have accelerated phase at diagnosis do very well with tyrosine kinases. And a lot of the early studies, including in fact the Irish study, some patients there who were called chronic phase by some criteria would have been called accelerated phase. That's very different than patients who develop accelerated phase during therapy. Those are very bad actors and have to be taken quite seriously. But with accelerated phase patients at diagnosis, you might line up and talk to some transplanters, but you should really give them a fair try on the tyrosine kinases first. T315I mutations, we have getting more drugs now with the axitinib on board, but in case you need to think about transplantation, this is the evidence that transplantation works quite well with T315I mutations. The left are patients with transplant, the right are patients who had T315I mutations without transplantation. These are patients, however, who did not receive imatinib or ponatinib. So in the setting of the availability of those 2 drugs, these curves might be definitely better. The other thing to remember is that tyrosine kinases does not affect transplant results. These are data from the Hutch, looking at chronic phase, accelerated phase, and blast crisis, and especially for chronic phase, accelerated phase, previous use of tyrosine kinase doesn't influence outcomes at all. So don't be reluctant to bring them in transplantation just because they've had years and years of TKIs. But it's important to remember that transplantation does not create immortality. These are Hutch data out to about 40 years. And people die of relapse, although relapse after 10 years is exceedingly rare, about 0.3% per year, but it does still happen progressively. But people die of complications of GVHD, people die of complications of just getting older. So what's to do about transplantation now? When Amanda first came out, remember it was called STI 571, and my friend Hagop Kantarjan immediately declared the STI stood for stop transplantation immediately. I would bet that now it should stand for some transplants are indicated. And here's sort of a flow diagram to think about it. If you think about it in chronic phase, you take a patient and give them tyrosine kinases. If they hit their milestones, which most will, hooray. If they don't, you switch. If they hit their milestones, hooray. If they don't, think about transplant. If they're accelerated phase after progression to chronic from chronic phase, they should get a TKI on the bridge to a transplant. Blast patients should get chemotherapy and a TKI and then go to transplant. So finally, who, what, when? Who should we transplant? Chronic phase patients. There are some patients who we get about 5 at the Hutch year who are just intolerant to all of these TKIs and just can't take them. They're never going to get enough exposure to the drug to be beneficial. So they need to go to transplant. If the TKIs, if 2 or 3 have failed the patient and become resistance, that's a pretty good indication. And if T315I, if you cannot get access or they cannot tolerate ponatinib or axitinib. Accelerated phase patients get transplanted if TKI failure, and blast phase should go after a TKI containing regimen to debulk them. When should we try transplant? Chronic phase, if trying salvage after 3 months of the trial, I showed some of that data. Accelerated phase blast crisis, whenever you get a donor available. And what type of transplant? Ablative if tolerable. In most people's hands, you go up to unablated donor to about 55 years of age. Non-myeloablative if they're older or sicker. Generally, chronic phase only because the non-myeloablative may have enough punch, not have enough punch to take care of blast crisis cases. And the usual rule is match-related donor versus unrelated donor versus haplo versus umbilical cord. Although there are some places in the U.S. that, particularly Johns Hopkins, is that haplo would jump in front of the unrelated donors. And that's my summary. Please, I welcome any questions. You can email me and I'll do the best I can. Thanks very much.